Welcome back, coders, to this highly anticipated masterclass explainer. I'm Harshal, and today we're stepping right into the absolute critical zone of EM coding. We are going to bulletproof your claims against audit risks when it comes to advanced care planning and cognitive assessment services. Now, these are high-value, time-intensive codes, but they are incredibly specific in their documentation requirements. You miss one element, and boom, your claim gets denied. So, grab our notebooks because we're going to dissect the CPT rules, those tricky time thresholds, and CMS coverage guidelines so you can code this with absolute confidence.
Okay, let's dive into this. Here's our roadmap for today. We'll start with advanced care planning basics, then hit the ACP time and billing rules. After that, we'll shift gears into the cognitive assessment scope, break down the 10 mandatory clinical elements, and wrap up with CMS limits and non-duplication rules.
All right, Section 1, Advanced Care Planning Basics, Defining the Scope. So when you look at the explicit language in the CPT manual, Advanced Care Planning, or ACP, is absolutely not just a casual chat at the end of a visit. It represents dedicated, face-to-face time spent by a physician or a qualified healthcare professional with a patient, a family member, or a surrogate. We're talking about counseling and discussing advanced directives, things like living wills, healthcare proxies, durable powers of attorney, and those really important end-of-life care goals. Now, a quick caveat here, actually completing the legal forms isn't strictly required to build a code, but that high-level, face-to-face medical decision-making and counseling regarding those future decisions, that absolutely is. Moving right along to Section 2, ACP time and billing rules, thresholds and modifiers. Let's break down the math, because this is where folks get tripped up. ACP codes operate on the midpoint rule. For your base CPT code 99497, which covers that first 30 minutes of face-to-face time, you have to cross the midpoint. That means your provider must document a minimal of 16 minutes to legally bill the base code. Pretty straightforward, right? But what happens if the conversation is highly complex and it just runs long? Well, that's exactly where your add-on code 99498 comes into play for each additional 30 minutes. But listen closely to this part. To bill that add-on code, you need at least 16 minutes beyond the initial 30-minute block. So mathematically speaking, you cannot bill 99497 and 99498 together unless the total documented face-to-face time hits exactly 46 minutes or more.
Now let's introduce modifiers into the mix. You are going to see advanced care planning performed on the same day as other services all the time. If ACP happens alongside a routine EM visit, let's say a 99214, you've got to append modifier 25 to the EM code. That just shows it was a significant, separately identifiable service. But here's a golden nugget for you. If the ACP is performed on the same day as a Medicare Annual Wellness Visit, or AWV, you actually append modifier 33 to the ACP code. Why do we do that? Because it flags the system that this is a preventative service, which effectively waives those Medicare cost-sharing deductibles and copays for the patient. Honestly, it's just excellent patient care paired with excellent coding practice. Okay, Section 3, Cognitive Assessment Scope, the comprehensive evaluation.
Listen, CPT 99483 is not your run-of-the-mill office visit. This is a highly comprehensive evaluation specifically designed for new or existing patients exhibiting signs of cognitive impairment. We are talking about severe conditions here: Alzheimer's disease, vascular dementia, or mild cognitive impairment. And because of the nature of these conditions, the patient themselves often just can't provide a reliable history. Therefore, this code usually necessitates an independent historian. Think a spouse, an adult child, or a caregiver who can actually step in and provide an accurate picture of the patient's cognitive decline. Now, let's talk time. While the CPT manual notes that typically 60 minutes of total time is spent on the day of the encounter, the strict requirement to successfully bill this comprehensive evaluation means you need a minimum of 50 minutes of face-to-face time spent by the provider with the patient and/or the caregiver. This is a heavy lift, which is exactly why the reimbursement for this code is so substantial, but it also means auditors are watching it like a hawk. Moving on to Section 4, the 10 mandatory clinical elements, bulletproofing your EHR. Straight from the AMA's CPT manual, we have an exhaustive list of required elements to build up this 99483 code. You can't just guess what goes into the provider's note here. The AMA has laid it out step by step for us. And let me be perfectly clear. If you miss even one of these 10 elements in the EHR, the entire claim falls apart upon audit. It's really that strict. So let's run through the first 5. I want you to mentally check these boxes right now, as if you were auditing a note yourself. First, you need a cognition-focused evaluation using a standardized tool. Second, the medical decision-making must hit moderate or high complexity. Third, a functional assessment evaluating basic and instrumental activities of daily living. Fourth, you absolutely must document the staging of the dementia using a recognized scale, like the FAST scale or the CDR. And fifth, a thorough medication reconciliation, specifically looking for any high-risk medications that could actually be exacerbating the cognitive issues.
Continuing our checklist, the sixth element is an evaluation for neuropsychiatric and behavioral symptoms, something like depression. Seventh, a safety and fall risk evaluation, which explicitly includes assessing their ability to operate a motor vehicle. Eighth, identification and interview of the caregiver to assess their needs and willingness to take on caregiving tasks. Ninth, the development or review of an advanced care plan. And 10th, guys, auditors literally feast on this one, the creation of a written care plan that addresses all these issues, which must be physically or electronically shared with the patient or caregiver. If that note doesn't explicitly say, care plan given to caregiver, you fail the audit. Period.
Finally, Section 5, CMS limits and non-duplication, the anti-overlap rules. When we look at the CPT guidelines regarding cognitive assessment, they explicitly cap 9943 at being reportable only once every 180 days per patient. So remember, this is not a monthly chronic care code. This is a comprehensive, deep dive evaluation meant to establish or confirm a major diagnosis and set up a care trajectory. Hence that strict 6-month frequency limit by a single physician or QHP.
Furthermore, we have absolute prohibitions on double dipping your time. You cannot overlap the time spent on 99483 with other time-based care management services. That means absolutely no double counting your time with Advanced Care Planning 99497, Chronic Care Management, or Psychiatric Collaborative Care on the exact same calendar day. The time has got to be distinctly separate, or it just cannot be billed. If your provider spends 60 minutes with a patient, you can't just magically carve that up to bill 99483 and 99497 simultaneously without meeting the independent time thresholds for both.
So the big question is, are you leaving revenue on the table by undercoding? Or even worse, are you inviting a massive audit by missing a single element in your 9943 documentation? Master these rules, cross-check your EHR templates, and I promise you'll be bulletproof. Ask yourself right now, if an auditor pulled your top billing provider's notes today, would they survive the 10-element test? Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.